So we see jaundice. In this lecture, we are seeing how to work up a patient who presents with jaundice. Now, what is jaundice? Jaundice is actually the yellowish discoloration of the sclera and the mucous membranes. It has to be differentiated from the yellow color which is produced by carotenemia, maybe which is seen in hypothyroidism. So the differentiating feature is that in carotenemia, the skin or mucous membrane may be yellow, but in jaundice, the sclera is also yellow, which is not yellow in carotenemia. Now, when a patient presents with jaundice, what you see, first thing you see is this jaundice accompanied by pain, that is upper abdominal pain. It is with pain or it is without pain. Now we see if the patient has jaundice and has pain, what we see is the jaundice developed acutely or the jaundice has been a chronic presentation. In acute jaundices, if the patient has medical conditions like hepatitis, patient may have jaundice, patient may have pain, that pain may be because of pancreatitis. Similarly, patients who got painful jaundice, they may have surgical jaundice. This may be caused by a stone in the biliary tract, maybe sometimes a blood clot, or rarely an ascaris stuck in the bile duct causing colicky pain. So if the patient has acute jaundice, the pain may be because of the associated pancreatitis in medical conditions, or patient may have obstruction to the biliary tree. And then if the patient has a chronic jaundice, we see if this is associated with intermittent pain, the patient may have stones, but if there is a persistent pain which does not go away, the most likely diagnosis is that patient is carrying a malignancy. Now we see what happens if a patient presents without pain. We see the development of anemia and the presence of GI symptoms. If this is an acute jaundice and the patient has GI symptom, this is most likely hepatitis, which may be because of viral diseases, it may be because of the drugs, or maybe some chemical causing it. And if the patient develops acute anemia and there is jaundice, this is a hemolytic jaundice. Acute anemia is characterized by the changes in appearance of the patient becomes more pale, there may be dark colored urine, and patient may have cardiovascular decompensation. And then if the patient has chronic jaundice and has vague symptoms like fever, body aches and pains, there may be anorexia, there may be unusual fatigue, the patient is suffering from most likely hepatocellular disease like chronic viral hepatitis. And if the patient develops pruritus, this pruritus is with jaundice and without any skin rash, this points most likely towards the obstructive jaundice. And if the patient has chronic jaundice, there is anemia and there is organ enlargement, that means a chronic hemolytic process is going on, which may be like hereditary spherocytosis or elliptocytosis, or the patient has autoimmune hemolytic anemias. And if the patient has only jaundice and there is no abnormality, this may be the chronic syndromes of congenital hyperbilirubinemia like Gilbert syndrome or the Crigler-Najjar syndrome. Now, how to work up these patients? There are two main important investigations, the ultrasound and the LFTs. The ultrasound tells us the bile ducts are dilated or the bile ducts are not dilated. That differentiates it from obstructive and non-obstructive jaundice. Then we go for liver chemistry. Liver chemistry is very helpful. Patient has got a high bilirubin. We see what type of bilirubin it is. If the patient has both conjugated and unconjugated bilirubin in the same proportion or similar proportions with abnormal ALT and AST, this is hepatocellular jaundice. If there is more of conjugated bilirubin and patient has more of alkaline phosphatase and gamma GT, this is a cholestatic type of jaundice. And if the patient has an unconjugated hyperbilirubinemia with normal enzymes, this may be a hemolytic jaundice or a syndrome of congenital hyperbilirubinemias. Now, if the patient has dilated ducts, we can see that this is because of the obstruction. But if the ducts are not dilated, the liver chemistry helps us differentiating that this is a cholestatic jaundice or this is a hepatocellular jaundice. Depending upon this, we further investigate the patient. Now, if the patient has dilated bile ducts, we have to find out what is the reason of this obstruction and dilatation of the ducts. So we need other tests. We may be needing more imaging. The non-invasive imaging includes the CT scan and the MRCP. This can tell us about the outline of the biliary tree, if there are any masses present inside or outside the bile duct. So that can be very helpful. Similarly, we can have invasive investigations, like we can have endoscopic ultrasound or we can have an ERCP, or sometimes if ERCP is not possible, we can go for a percutaneous cholangiogram, and then we may be helped by some of the tumor markers if we find images indicating that there is obstruction because of masses. So different type of tumor markers like CA19.9 or CEA, carcinoembryonic antigen, may be done to assist us in making a diagnosis. And if the patient has normal ducts, this may be because of the hepatocellular disease. For example, when a patient has both combined hyperbilirubinemia of equal proportions and abnormal ALT, AST, we go for viral screen, take the history of drugs, go for a metabolic screen for Wilson disease, hemochromatosis, or autoimmune conditions, or if the patient might have this because of consequence of NASH. And if the patient has cholestatic type of picture, go for autoimmune screen, that is mitochondrial antibodies, or go for drugs which cause cholestasis. And if the patient has hemolysis, then go for a peripheral film indicating what sort of RBC morphology is there. Go for direct antiglobulin test, flow cytometry to see if there is PNH, G6 phosphate, dehydrogenase activity, and go for the history of drug screening that may cause hemolysis. For example, ribavirin may cause hemolysis. So this is how we go when we get a patient who is